Hello guys, good evening. So we're back again with the eye images now. So are you all ready? I know Sunday too much of Ophthal, no? But anyway, by the end of your revision schedule, at least the revision schedule that I have in mind, you should be thorough with ophthalmology for INICET and your NEETPG exam, and also for the upcoming FMG exam. I'm sure this is going to help you because there are a lot of images that come in ophthalmology, not as a separate paper, but anyway, in ophthalmology, a lot of images. So one or two at a time, I think that's going to be very, very useful to you. So shall we start with the first image? So the first image is very, very easy. Very, 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 very easy. What can you see here? Yes, it's one of our favorite images of animal, cuddly animal. Good evening, Vinod. So what sign is this? What is the name of this sign? Yes, this is periorbital ecchymosis. Yes, you can see the bleeding around the eye. So that is these is periorbital ecchymosis. Panda sign, also called as a raccoon sign. Okay, panda sign, also called as a raccoon sign. Okay, raccoon is your tevang. I don't know in Hindi what is the name. Okay, so panda sign or raccoon sign. So that is what this is. So when you see this, you will always have to rule out base of skull fracture. So this is definitely trauma because I can see subconjunctival hemorrhage as well. Yes, I can see the redness inside. So always rule out base of skull fracture. And also as an ophthalmologist, please look at bruising behind the ear, the battledore sign. Then if there is any epistaxis or bleeding from the ear, all this points towards base of skull fracture. And also maybe even anterior cranial fossa fracture. That is what causes this kind of spread of blood. Okay, so it is medico legal importance. So very, very important. Ask the patient for history of epistaxis, peep into the ear, behind the ear. Yes, all right. So anterior cranial fossa fracture, that is what results in this kind of picture, panda eyes or raccoon eyes. All right, shall we move to the next image? Very, very easy one. Next one. Okay, so here I also gave you a little history. So this is a 40-ish old man who had history of watering for the last 2 years. Now for the last few weeks or so, he has this mucoid discharge. Yes, there's no swelling, there's no pain, no swelling, no pain. What is the diagnosis? Rho plus. Rho plus is plus. So you can see the mucopurulent discharge coming out of the punctum. Yes, there's no pain, no redness. So that means it is not acute. Okay, what is Rho plus? ROPLAS. So when you apply pressure on the lacrimal sac area, there is regurgitation. Where is the lacrimal sac? Just below the medial canthus. Okay, so that is where your lacrimal sac is. So when you give pressure, there is regurgitation. Regurgitation on pressure, ROP. Okay, regurgitation on pressure over lacrimal sac, LA, lacrimal sac, S. Rho plus. So there is a mucoid or a mucopurulent material coming out. So that means there is dacryocystitis. Now is it acute or chronic? Chronic because there is no pain, no tenderness. Yeah. So, see, swelling may or may not be present in chronic, but definitely in this patient we say that there is no pain, and yes, he's been having watering for a longer period of time. Yes, so that means he's got a narrow NLD. Yes, not an obstruction as such, but the passage itself is probably narrow. So chronic dacryocystitis. So what is the treatment of choice for this patient? Of course, we'll give topical antibiotics, but treatment of choice is you have to do DCR surgery, okay, dacryocystorhinostomy, okay. So for this patient with a diagnosis of chronic dacryocystitis, because there is epiphora for the last 2 years, mucoid discharge or mucopurulent discharge, Vesabi, and also on Rho plus positive. So regurgitation on pressure over lacrimal sac positive, no pain, no tenderness. That is why it is chronic dacryocystitis. And in adult chronic dacryocystitis, the treatment of choice is DCR surgery. What is DCR? Dacryocysto-rhinostomy. Okay, so dacryocysto is your lacrimal sac. So you're going to connect that with the nose by making a bony opening. Where does your NLD or your nasolacrimal duct normally open into? It opens into the inferior meatus of the nose. Yeah. But now we're going to bypass this NLD and directly connect the lacrimal sac with the medial meatus of the nose through a bony cavity. Through a bony opening. So DCR surgery is the treatment of choice for chronic dacryocystitis. Yes, Vinod, absolutely correct. Yes, so can we go to the next image? So now it's a posterior segment image. So what type of optic atrophy can you see in this image? What is the type of optic atrophy, or what is the sign that you actually see? I think that was the question. What is the sign that you see? See, you're seeing a glaucomatous optic disc. Yes, because your CD ratio is very much increased. So your neuroretinal rim is so thinned out. Can you see the bending of the blood vessel? So your cup, rim of your cup here is here. And can you see the bayoneting sign? Yes. So your cup is from here to here. The cup is almost 0.8, 0.8. Yes. So your cup is enlarged and you're seeing the laminar dot sign. Yes, very good. You're seeing the lamina cribrosa. Good, Shweta. Good. Very good. Yes. So you're seeing the lamina cribrosa. You're seeing the openings of the lamina cribrosa. What is lamina cribrosa? That scleral part of the sclera which has openings so that your optic nerve, the axons of the optic nerve can pass behind. Can you beautifully see the lamina cribrosa? Lamina dot sign, and can you see the bayoneting sign? Yes, can you see the bayoneting, the sharp angulation of the vessel? In fact, it's a little shallow here, but yes. Can you see the increased CD ratio? Can you see the increased CD ratio? The CD ratio, enlarged cup. The neuroretinal rim is so thinned out. Yes, so what is the diagnosis? Beautiful, isn't it? What is the diagnosis? What is the diagnosis of this optic disc? Yes, glaucomatous. Very good, Vinod. Glaucomatous optic disc. And what is the type of optic atrophy that you get in glaucoma? Based on the morphology, what is the type of optic atrophy? Very good, Shweta. Very good. Yes. So what is the type of optic atrophy characteristically based on the appearance of the optic disc? Cavernous type of optic atrophy. Okay, cavernous. Very good, Shweta. So cavernous means gufa jaisa. Okay, it's like a cave. Koha madri irukla. It's like a koha. See, that is why it is so excavated. That's why you're able to see the lamina cribrosa. See, the cup is like a saucer. Okay, it's kind of shallow, but now it's like a cave. So when you peep into it, it's like a cave. Yeah. So cavernous optic atrophy in glaucoma. And this one, what is the diagnosis? What is the finding? So here it's a dilated pupillary margin. Okay, can you see the dilated pupil? And the lens, there is a defect in the lens. So this is a lens coloboma. Congenitally, the lens is missing. A little bit of lens is missing. See, normally when you see from the front, the lens will be circular. But here it is missing. So this is lens coloboma. Yes, because in this area, the zonules are congenitally deficient. This area. Yes, so you get a lens coloboma. Very good, BU. Yes, absolutely. Brilliant. So can you see a lens coloboma? All of you, can you make out this? So this blackish area, that area, the zonules are not there. See, normally you will have zonules 360 degrees. Okay. So this is my circular lens, 360 degrees. It's like sun rays. Okay. So you'll have zonules all around. But one area, or in this area, there is no zonule. Okay. So the lens shrinks in that area. So that is called lens coloboma. Yes, all of you able to appreciate lens coloboma? Yes, it's a surface ectodermal defect. Brilliant, BU. Badya. Oh no, it's not a surface ectodermal defect. Very good that you said that. See, that's why, see, you're not part of my regular course now. Anyway, we'll be doing that in the test and discussion. See, zonules, that is your tertiary vitreous, is a derivative of neuroectoderm. Yes, zonules. So this is primarily because of a problem of the zonules. Okay, this is a problem of zonules. So when my zonules are missing here, that means it's a neuroectodermal defect. Because of that, it's a secondary change consequence on the result is seen on the lens. Although lens is a surface ectodermal derivative, this lens coloboma is a neuroectodermal defect. Understood? Got it? Because zonules la problem. See, there is congenital deficiency of zonules resulting in this lens being pulled inside. See, the lens, the zonules are like rubber bands, okay, stretched rubber bands. So they pull the lens and keep it in a circular shape. So if one area, the zonules are not there, okay, in this case, it's here, no, it's not there, the lens will shrink. Zonules, tertiary vitreous, derivative of neuroectoderm. So lens coloboma is a neuroectodermal defect, although lens itself is a surface ectodermal derivative. Lid coloboma, purely surface ectodermal defect. Okay, lid coloboma is a surface ectodermal defect, nothing to do with neuroectoderm. Got it? Everybody? Everyone got it? Alright, see, I got you there. Good that you made that comment. Okay, தெரிஞ்சு சொன்னியா தெரியாம சொன்னியான்னு எனக்கு தெரியல, நான் அளவிட சொன்னேன். Seri, okay, let's go to this image, examiner's favorite, right from the days of my All India days till now. Okay, so this is your baseline. Baseline means primary gaze. Primary gaze, both eyes are looking straight. Okay, now look at the second image, the middle image. So middle image, the patient is looking to the left. Okay, patient is looking to the left. Left eye is abducting well, right eye is adducting well. Very good. Now when the patient is looking to the right, yeah, as you see the image, we'll describe it like that, forget whatever is written there. Now the patient is looking to the right. Right eye is abducting, left eye is not adducting. See, primary gaze normal, left gaze normal, right gaze abduction is normal, only the adduction there is a deficit. Okay, and also they have written above the abducting eye there is nystagmus. So when I have an adduction deficit and an abducting nystagmus, this is internuclear ophthalmoplegia because of MLF lesion, ipsilateral adduction deficit. Yes, ipsilateral adduction deficit. That is where I will have medial longitudinal fasciculus lesion. So in this case, I have a left MLF lesion, which is causing a left adduction deficit and a contralateral abducting nystagmus. Yes, right abducting nystagmus. So this is a case of right internuclear ophthalmoplegia. Very good. Yes, Rafi, very good. Al-Rafi, very good. Yes, so this is a left MLF lesion. That is your left INO, left internuclear ophthalmoplegia. But yeah, very good, Shweta. Very good, Vinod. Yes, perfect. So I guess that's all we have. So those are the images, 5 images and the discussion. Yes, confident, you'll not make a mistake. Are you starting to love ophthalmology? Yes. All right. I just hope you're finding it interesting to learn. So keep revising, keep revising. So the new schedule of the quiz will start from tomorrow. Telegram quiz, 6 p.m. Telegram quiz. I'll put up the schedule in the group in a little while. And so I will see you with the first discussion, whatever is the topic, I don't remember. So that one I will see you as always at 11. So 11 a.m. is our morning ritual. So morning 11 a.m. I will see you on Tuesday. Okay. So study well and don't take too much of a break because your life is important. Okay. So see you Tuesday. Ciao.